Hello, my name is Susie McDevitt. I am a nurse practitioner at the University of Michigan Pulmonary Hypertension Program and clinical adjunct faculty at the School of Nursing. So today we're going to talk about some of the clinical pearls for PAH and PH-ILD management with Tyvaso DPI. So remember that pulmonary arterial hypertension or group 1 PH and pulmonary hypertension associated with interstitial lung disease or group 3 PH are both forms of precapillary pulmonary hypertension. They have a similar hemodynamic profile, and of course, the diagnosis is confirmed by right heart catheterization. So hemodynamics will be consistent with an elevated mean pulmonary artery pressure greater than 20 millimeters of mercury, a normal left-sided filling pressure or pulmonary capillary wedge pressure less than or equal to 15, and an elevated pulmonary vascular resistance greater than 2 Wood units. So you may see more advanced hemodynamics in group 1 than versus group 3. Remember that pulmonary hypertension is considered common in interstitial lung disease. In early ILD, about 5 to 15% of patients will have PH, and in advancing ILD, up to 86% of patients at the time of lung transplant will have some pulmonary hypertension. So it's important to be evaluating for this. We talk about PH-ILD as having a vasculature fibrosis interconnectivity. We see pathologic vascular remodeling, fibrotic destruction, sustained hypoxia, and vasoconstriction. This is a really tough disease burden for our patients to manage. Anyone who's taken care of them knows this. They're very symptomatic patients. Tyvaso, or inhaled treprostinil, is a prostacyclin analog for the treatment of PAH and PH-ILD to improve exercise ability. So prior to the approval of Tyvaso, there were no approved therapies for PH-ILD, as all other previous randomized controlled trials failed to meet the primary endpoint, unfortunately. So Tyvaso was initially FDA approved in 2009 in the nebulized formulation. Tyvaso DPI, or dry powder inhalation, is a newer drug-device combination therapy that has been more recently developed. And we know that DPIs have been used for decades as a simple way to deliver medication to the lungs while minimizing systemic adverse events. DPI devices can vary considerably in terms of their characteristics. So Tyvaso uses a small, portable, reusable, breath-powered dry powder inhaler. And this is a tremendous advancement for our patients as it provides a simpler option, which may improve their compliance and adherence, and it provides a comparable level of systemic exposure to the nebulizer formulation. Tyvaso provides drug delivery to the lung vasculature, which gives us an immediate local drug availability with some advantages. Number one, there's minimal systemic exposure with this route of administration, and that potentially minimizes the systemic side effects that we see with other forms of prostacyclin, including oral and parenteral formulation. Also, Tyvaso is delivered to the healthy, non-fibrotic parts of the lung, the functioning alveoli, and this may reduce that overall VQ or ventilation perfusion mismatch, which is an important consideration in our patients with PH-ILD who are already prone to hypoxia, and they're at risk using our PH pulmonary vasodilator therapy. So in terms of the technical characteristics of this DPI system, this is considered a high-resistance, low-flow device. Our goal is to get the medication into the deep lung periphery, and this is achievable with DPI due to the small particle size. It's 1 to 5 microns, the powder deaggregation and dispersion that happens with the device, and importantly, the low-flow characteristic. So low flow allows for more time for the drug to be deposited into the lung periphery. High flow devices will have more drug deposition in the oropharynx and in the upper airways, and that may lead to more cost and may lead to less efficacy. So this device is considered high resistance, which is achievable by our patient, and low flow. The single-use pre-filled cartridges are color-coded for dose, so it's quite simple for patient use. And they come in doses of 16, 32, 48, and 64 micrograms. If the patient's on a higher dose than 64 micrograms, we use 2 cartridges. Each dose is 1 breath and takes about 2 seconds, and the patient does this 4 times a day. So in terms of clinical studies, remember that the pivotal PH-ILD study was the INCREASE trial. This was a phase 3 randomized placebo-controlled trial of 326 patients, which demonstrated improvement in 6-minute walk distance and decreased risk of clinical worsening in PH-ILD using the nebulized formulation. The Tyvaso DPI study was the BREEZE trial, which was an open-label safety and tolerability study. This included 51 PAH patients who were stable on nebulized Tyvaso, who transitioned to the DPI formulation for 3 weeks, followed by an open-label extension phase to assess long-term safety and tolerability. This open-label study demonstrated improvement in 6-minute walk distance after 3 weeks of 11.5 meters, as well as improvement in patient satisfaction. The adverse event profile was similar to previous studies, with 35% experiencing cough and 16% experiencing headache with Tyvaso DPI. Importantly, some patients were able to achieve higher doses than previously reported, with 6 patients achieving the 112 microgram dose, which is equivalent to about 23 breaths of nebulized Tyvaso. So in terms of patient selection for this therapy, we certainly want to practice evidence-based medicine and we want to practice shared decision-making. And we can reference the 7th World Symposium on Pulmonary Hypertension, where Group 1 PAH patients not meeting goals of therapy, already on dual oral background therapy, who remain at what we call intermediate low risk on the 4-strata risk calculator. So these patients have not improved to low risk status. These may be appropriate for use for add-on inhaled Tyvaso. Also, patients who are declining or not meeting goals of therapy and who are deemed not appropriate candidates for the use of IV or sub-Q therapy, we may consider inhaled therapy. Also, patients with group 3 PH associated with interstitial lung disease may be considered for this therapy. So when we start therapy, remember the initial nebulized formulation starting dose is 3 breaths QID. And when using DPI, we generally start at 16 micrograms QID and increase every 1 to 2 weeks to an initial target dose of 48 to 64 micrograms QID. Remember that each 16 microgram increment corresponds to about 3 breaths of nebulized Tyvaso, and each patient should have an individualized titration schedule and goal dose based on their pulmonary hypertension findings, their severity of disease, and their characteristics of ILD. We try to set the patient up for success when starting therapy. Patients with PH-ILD may have more cough and throat irritation, so we may have more success titrating low and slow. And remember, cough and ILD, for those of you who care for those patients, you know so well that cough can be really significant. It can lead to hypoxia and presyncope and syncope. So we work hard to try to prevent and mitigate cough with this therapy. I have definitely titrated some of our PH-ILD patients, very gingerly, going up by 1 of the 4 doses daily for a few days, and then up to 2 of the doses and up to 3 of the doses, and finally get all 4 doses titrated up. And we've had some success using this slower approach. We tend to use shared decision-making on which formulation the patient would like to start with. We also remind our patients we can trial one of the formulations, and certainly we can switch to the other formulation if there's any concern. So we want to be proactive with managing side effects, and now there are multiple publications with cough mitigation strategies for this therapy to reference. It's important to set expectations with the patient and remind them our goals of up-titrating are to improve their exercise capacity. We want them to be able to do more, and we want to decrease their symptoms of pulmonary hypertension. We remind them that they may have some side effects during the initiation phase and the up-titration phase, and that their PH care team will help alleviate these. Also, the BREEZE study showed that adverse events may improve over time, and so this is important to share with patients. The goal is to achieve the maximum tolerated clinically indicated dose for each patient. And this individualized dosing that we have with Tyvaso is really a nice feature of the therapy. So patients starting on inhaled prostacyclin therapy should have multiple touch points by their PH care team and close follow-up. So I hope this was a helpful review of some of the basics with Tyvaso DPI therapy for PAH and PH-ILD. For more information, feel free to visit the APAP website at apap.org. Thank you so much for joining today.